from uncertified recovery residences. So I don't want to put Kelly Lee on the spot, but hopefully she's paying attention to Miami-Dade, or at least sending it their way, because every single provider is required to list the recovery residences that they work with on their applications and renewals. So it should be pretty easy to identify those residences that are not certified and engaging in referrals. So we can take action, or at least get them educated and get them certified. So okay, thank you, Josh, for your update. And before we go to I believe it's Mike Pacchio from Oxford House for an update. I do want to mention that
Al, I had my hand up really quick for that.
Oh, I'm sorry, Jeff. Go ahead.
Yeah, someone took it down for me, but I put it back up. No, I think Josh is being politically correct and nice. And I see someone is here from Siobhan Harris's office, and you know, Kelly Lee's not over Dade County, but anecdotally, we've been led to believe that the office down there that is separate than Broward and Palm Beach. I can't prove this, but we've heard through the grapevine that basically they're like, we're not enforcing that law, and about oversight about referrals to DCF. I mean, to FAR certified recovery residences. So I think the culture needs, I can't prove this. I'm saying this is just what we're hearing on the street, is that the DCF office in Miami doesn't believe in that law, and therefore it is not requiring its license holders and others to adhere to it.
Okay, well, we'll follow up on that.
It might just be an education thing, but I'm just saying is that's why my understanding is why we have these ridiculously low numbers in Dade County, which make no sense.
Well, there are a couple other places as well: Orlando, Jacksonville, Duval County. But okay, thanks, Jeff, for that. And now we have Oxford House numbers. By the way, I did some math based on what you submitted, and in the state of Florida, combining Oxford House with FAR, we have 10,493 beds in the state of Florida, which is, I would say, probably triple any other state between Oxford House and certified NAR certified recovery residences. So we're really doing well. So Mike, why don't you go ahead and talk about Oxford House now?
Sure, thank you, Al. Just want to throw out there for Terry. So we do have 3 Oxford houses in the north part of the county down there, and we are working on getting more Oxford houses down there as well that can be referred to from treatment facilities. So Oxford houses in the state of Florida, 164 houses currently, a total of 1,492 beds. A total of 102 men's houses with 924 men's beds. We have 25 women's houses with 218 beds, 34 women and children's houses with 321 beds, and then 3 men and children's houses with 29 beds. In quite a few cities across the state, some of the new ones that we've added since the last meeting: Crestview is more of a rural area up there in the Panhandle. Naples, and then Spring Hill north of Tampa over there. A few more cities that we're looking at, and there's actually a couple more to add to that list that we're planning on getting going here pretty soon. Overdoses, since the last meeting we had one non-fatal in the Orlando area, reversed with Narcan, thankfully. So overall, the Oxford House Initiative in Florida is continuing to gain momentum with various chapters actively engaging in community building and recovery efforts. Across the chapters, there's a clear emphasis placed on education, with initiatives like newcomer orientations and workshops geared towards deepening members' understanding of the Oxford House model. Alongside these educational endeavors, there's a strong focus on community and unity building activities, ranging from fundraisers to holiday celebrations, creating an energetic and supportive atmosphere within the network of homes. The commitment to outreach is a standout feature of the Oxford House network in Florida. Members and staff actively participate in local recovery events, have collaborated with law enforcement through presentations with different agencies, and contribute to community resources. This collective effort underscores a shared dedication to creating a sense of togetherness, evident in events like Thanksgiving and Christmas dinners, as well as regional trainings. As the chapters look ahead, there's a proactive approach to sustaining this supportive environment with future goals of continuing to open new houses in new areas, event hosting aimed at continual community building and ongoing training activities. And so all of that rings true. The network of houses for Oxford House is growing throughout the state. The staff and the membership and the long-term membership and the alumni are working beautifully together. And it's really this huge just community with growth and a lot of people gaining long-term sobriety. All of our Oxford houses accept people that are on medically assisted treatment. And there's a lot of there's many good things happening throughout the state as far as Oxford House is concerned. We did get some statistics from our annual survey. They haven't really published it yet, but we got the sneak peek at some of the stats here. And so this is from the very large majority of the members. I think is 98.3% of the members at that time. It was done in this last summer that participated. So over 1,000 people. So we have an average length of sobriety amongst the Oxford House membership at 333 days. Members who have reported opioid misuse in their past, over 60% there. Members who reported use of medically assisted treatment, whether that's current or in the past, 41.2%. Members who have reported stimulant misuse, 80.7%. Average number of times members tried to get clean and sober prior to their stay currently in Oxford House, 7.2. Average number of times a member has been to detox without continuing to treatment, 2.9. Average amount of 12-step meetings attended per week by the members, 4.5. Members attending counseling and 12-step meetings, 40.4%. Importance of Oxford House to members' recovery. At that time, 1 being unimportant, 5 being important, and it was rated at a 4.7. We have some upcoming events. We have our state workshop, which is going to just bring a lot of our membership across the state together, and there'll be some awards and speakers and some really great things happening there. And then our World Convention we're hosting in Orlando in October, and just an amazing event there. All of the chapters are still working on getting everything squared away with DCF to be Narcan providers in the state so that Narcan can be easily available for all the houses and all the members in any shape, form, or fashion that looks like.
Great, thank you, Mike. Appreciate it. It's remarkable, the first 3 years of this task force, there wasn't a single Oxford house in the state of Florida. And now there's 164 houses with 1,492 beds. That's remarkable. Same thing with FAR, the progress. I do want to make mention just briefly that a couple of weeks ago, I had the pleasure of meeting with Secretary Harris and Gail Harrell, and we had a very pleasant and informative conversation. And very pleased and happy that Secretary Harris has come to observe the meeting today. So don't get too stressed out, Kelly Lee. I think you're okay. But anyway, welcome, Madam Secretary. And now we have a presentation from the Southeast Florida Behavioral Health Network.
Al, I believe Terry had a question.
Oh, I'm sorry. Terry, go ahead.
You're on mute, Terry.
Thanks, Mike. You're always there to help me out, man. Thank you.
Yeah.
I was just waving to Siobhan Harris, welcoming her. That's all.
Okay.
Thank you, though.
Hi, everyone.
Hello, Madam Secretary. Now, I do want to apologize. Ann Berner's been on this. At first, it was a Sober Homes Task Force. Now it's the State Attorney Addiction Recovery Task Force, better name, since the very beginning. And I forgot to call the roll with your name, so I apologize for that. But you have a presentation for us regarding the continuum of care and what you the plans you have for 2024?
I do. Thank you. It's been a while since I've had an opportunity to present, but it's been a lot of things happening, and so it seemed like a right time to kick off the new year. And I know I am time limited, so this is kind of a snapshot of the things that we've been working on, and hopefully, as you have additional questions, then I can certainly follow up with you. But let's see, I think we've got. Hopefully, my screen is sharing. And you've got my first page up?
Yep.
Al, is that right? Okay.
Yes.
All right. So we are the managing entity contracted with the Department of Children and Families. One of the pieces that there's been a lot of conversation around is about moving to a recovery oriented, maybe and partially away from kind of the acute care model. And so I thought it was helpful to first kind of put in scope some of the things that have been happening in this year. And I like to use current year information to the extent we can, because it's a constantly evolving process. There's new initiatives. We're bringing on new evidence-based programs, new providers. And so this first breakdown I wanted to share with you is that through our first 5 months of our fiscal year, so we follow the state fiscal year beginning July 1, we spent just over $28 million in Palm Beach County specifically. And so that doesn't include, a lot of you know that we also cover the Treasure Coast and Okeechobee. And then we also had a number of proviso projects that are in Palm Beach County and other locations. But this is just the services dollars that Southeast Florida has invested in Palm Beach County for the first 5 months. And then it annualizes out to be a little bit over 70 million. And then we've got the breakdown between community-based treatment. So those are the actual treatment services that we fund for underinsured and indigent. And then also in the event that insurance doesn't cover a service, a lot of private insurance, for example, doesn't cover case management or supported employment. And so we would pay for that on a sliding fee scale. And then, of course, there's the acute care, residential, and our community-based non-treatment services, right? So these are all of the different kind of programs and activities that we sponsor in order to make sure that we've got activities and engagement opportunities for people to develop meaningful social lives, for them to have those necessary supports, both formal and informal, that's available to them to promote their recovery. And so I thought it'd be helpful, and I'll say, well, what does that mean? What services are included in that? So for those of you who haven't looked ahead, here is a list of the specific services that we consider to be community-based treatment. And so that includes some of our team models. It includes specific services, and then a lot of the traditional kinds of treatment opportunities like medication, medical services and medication management. So that's access to psychotropic medications, access to Medicaid-assisted treatment, including the dosing, and then outpatient. And then, of course, one of the areas that we've expanded is in provider level care coordination, which is significantly different than case management, and an important piece where we support our providers in helping identify individuals who are not successfully engaged in services, and figuring out a better approach, a better engagement strategies, different services than maybe what's been offered, and some additional safety net services. And so that's been, I think, significant in our efforts in making sure that individuals, when they are ready for treatment, that we've got avenues in, and we've got individuals that can help navigate. So our community-based treatment is right around 28% of our dollars invested in behavioral health in Palm Beach. And then a breakdown of acute care, right? So acute care does represent over a third of our budget, just over $10 million through November. And that includes the actual crisis stabilization units. It includes a screening and intake process, and that's where individuals are brought in a lot of times by law enforcement or other individuals that can Baker Act, and they do that screening and assessment to determine if they in fact meet criteria and qualify for admission under the Baker Act. We also fund through South County a short-term residential program, which is like a mini state hospital and it is intended to divert individuals both from additional criminal encounters and from going into the state hospital. And so that's been in place for about 2.5 years now, and it has been a really effective approach to meeting the needs and keeping individuals here locally. And so that's a 15-bed unit on South County campus. So far this year, we've spent just over 1.6 million in mobile response teams in our 3 different locations: Belglade, Palm Beach Gardens, and Delray Beach. And then we also provide inpatient detox through Drug Abuse Foundation. And so those are our areas that we fund as acute care. And residential treatment. So we went through and looked at all of our residential treatment programs, and these were all the kind of the different funding areas. And so right now we operate about 20% of our budget. And you might say, what is a residential level 2, or what's a residential level 4? And so here is a breakdown of all of the residential programs that we provide here in Palm Beach County. And on the slide, you'll see the capacity and then basically the amount of funding that we have allocated for those programs. So in some programs, we provide the vast majority or almost 100% of the funding. And in others, we provide a small amount of funds for those beds. And they're generally more specialized and involved in some kind of an authorization process where we're making sure that we meet the appropriate level of care for the individual as they present. So I know you all have a copy of the presentation, so won't spend too much time, but we have tried to do a lot of specializing. So we have moms and babies beds at Drug Abuse Foundation, and we have Transpire that targets LGBTQ individuals. A lot of different of the programs. And so we really do try to have that continuum where we have different options for individuals depending on their need and matching of the individual to the program. And so that's about so far. So annually, we expect to spend about $14 million. The other important thing is that because a lot of this is block grant funded, residency requirements in the county of Palm Beach is not required. So any individual that presents and meets eligibility, primarily financial eligibility, would be eligible for services to be funded through state and federal dollars. Also, a kind of a snippet of how we count individuals served and our breakdown that we report to the department. And we do follow along the program lines, right? So the adult and children, mental health and substance use, and the various levels of care. And so, for example, so far this year, we've served in Palm Beach County just over 500 IV using individuals. And then we're tracking we funded services to 604 individuals for peer supports. And again, these would all be direct client services and wouldn't include counts for things like clubhouses, drop-in centers, or recovery centers. And again, this is just for through the first 5 months of the fiscal year. Also, this is an example of some of the performance outcomes that we monitor. So we do follow and depend on our data to identify individuals for care coordination. So we look at readmissions for crisis stabilization and individuals who have been readmitted to inpatient detox within 30 days. And so we look for those high utilizers, and specifically it would be any individual in a CSU for 16 or more days or a detox, and with 3 or more admissions within a 6-month time period. Some of the other, we're looking at annual days worked. We follow improvement in level of functioning. We look at individuals who are competitively employed, right? So we've got them individuals at least working part-time as a measure of meaningful engagement in the community. Housing, of course, is important. So kind of monitoring stable housing and looking that we're providing supports to meet the need for our vulnerable population. And then we also track employment from admission to discharge. And so those are just a few examples of some of the performance measures that we monitor. And then on any of the measures, we can also drill down by provider. We can drill down by the therapist. We can drill down by diagnosis type. So we can kind of hone in when we have a situation where maybe a provider isn't necessarily being successful, or they are being successful, and we want to know, who would be the most appropriate individual to refer based on a successful outcome trend or history. So again, those are just a few of the measures that we report out on frequently. And then, we've really experienced a significant increase in our funding. When we first started in 2012, our annual operating budget was just around $60 million. And this year, with excluding the proviso projects, we're up over $110 million that we administer. And some of the areas that we've successfully expanded is really quite an impressive list. We've brought online a central receiving system, and I'll talk a little bit more about that. But there's been a big initiative, and I know in working with the healthcare district, looking at how we utilize 211, 988, 911, and the mobile response teams. And so we've got some additional information on how those are functioning. I talked a little about provider care coordination, but there's also system level care coordination. And so that's really a problem solving group. We work with some of the most intense individuals, families who have not been successful, and it includes Medicaid, individuals enrolled in Medicaid that are not having the engagement that we would want. So whether it's criminal justice system, child welfare, juvenile justice, all of those different systems overlapping is addressed through system care coordination. I'm going to talk a little about our teams, which I think in the evolution of behavioral health, having a team approach has been really critical in helping stabilize the services to our individuals. You can all imagine, as you have a therapist who ends up maybe leaving and you kind of have to start all over again. We found that because there's a team approach and multiple individuals involved, the disruption in a therapeutic setting is offset some by the security and consistency of the team approach and having other individuals involved in their care. And so we've been really excited about that. We also see improvement in staff retention in those teams because it is more supportive, and there's a bonding with the team as they are able to problem solve. There's a safety element, and so we're really excited to continue to promote the team approach for a lot of our specialized programs. And then through some of the additional funding over the last couple of years, I mentioned the short-term residential. We've added a conditional release residential program through the Lord's Place, another 100 slots for FACT, and then our medication management, more transitional and respite services, and supported employment, and that's primarily through our clubhouses. Here's some more of the details specifically about that. So in addition to the FACT teams and some of the other teams that I mentioned, we have 2 teams in Palm Beach County that work specifically with our incompetent to proceed and our NGI population, and efforts to make sure that we're getting individuals out of jail as quick as possible, that we're helping prevent any further decompensation, and then working with them to keep from reoffending. And there's currently, right now, we are working on expanding our mental health court. And that's been through the leadership and stewardship of Commissioner Weiss, and one of his projects that he's been helping us spearhead. And so we appreciate his leadership on our mental health court expansion. And then as a result of a lot of those different interventions, these are some of the programs that then are available for diversion and support, so that it's not enough just to have case management or have peers available to help engage, you also have to have some place for them to go and things for them to do. And so I think this continuum that we've been building has been a important piece in establishing what options are available for our community. I'm so excited. No questions. We're going to keep rolling. Now, here's the exciting part that we talked about. And it kind of, it came up in some of our discussions with the healthcare district. And I think this is an area where we're really going to be able to coalesce as a community around implementing a central receiving system. And I think there's opportunities for sharing information about bed availability, because the central receiving system is really intended to do that triage and have psychiatric evaluations available with a lot of goals in mind, right? One is that we want to make sure that if someone did get Baker acted because of a medical condition, that it's correctly identified and that person can be taken care of and a Baker Act lifted so that they don't have to go any further into the system. We also want our law enforcement to be able to get back out on the field, back out to road patrol. And so having a central receiving opportunity does that. It allows them to get back out on the road. And I think in some of the best areas in the state, it takes as little as 8 minutes to drop off to deliver an individual who has been Baker acted to a receiving facility. So right now we have done a soft launch as of December 1st. There's still some more remodeling that's being done at the campus, which is on the St. Mary's Hospital right there on 45th Street. But I think that we still have some opportunities for easier drop off and additional entryways, and then the use of the chairs for that period of time when the evaluation is undergoing. But then again, even after these individuals are identified, the intent is not that they all stay at the crisis unit right there, but that the appropriate location is identified. So there'll be a lot more work that's coming and related to this, and being able to use the chairs the way they're intended. So we're excited to be able to get that up and going. And I know a number of us were working right before the holidays in talking about how we can best triage the front end of the system. And so we continue to support our 211, our 911, and our 988 through our primary providers, South County Mental Health Center with our mobile response teams, and our 211/988 call center. And is talked a lot about their credentialing process for them as a crisis triage, the use of the 988 versus the 211. And so I'm sure this will be an ongoing topic that hopefully we're all going to coalesce around and really figure out how to elevate the front end of the system for the very best possible outcomes. I thought it was important that we actually kind of dive down in some of the areas of the use of evidence-based practices and some of the outcomes that we're looking at, because part of the role of the managing entity is to be that safety net and provide a floor through which no family can fall further. And the family intensive treatment teams is definitely one of those areas. And the families that we identify for this program they are multiple encounters with child welfare, likely multiple removals, a lot of generational involvement, and so this is really an opportunity for them to restart and engage in a lot of different and creative ways to meet the families and include their perspective and their priorities. And so we have 2 teams here in Palm Beach County now that serve, each team serves about 30 to 35 families on average, and they can have a longer length of stay of 6 months to 12 months. And there's a lot of assessments and evaluations. And the results indicate that if there is a definite reduction, not just in removals, but in future calls involving child welfare, and that the families are better situated, highly more functional, better outcomes in school, and better long-term results. And so this program has been around a number of years now, but because it does have a very structured format, very specific tools that we use to measure families' progress, and because it is focused on the voice of the family and engaging them in what are their priorities, I think it's been one of the shining stars in our network array, and has been really important for families in general. And that again is available throughout all of Palm Beach County. This is one of our newest programs, and I know a lot of you are familiar with the multi-systemic therapy, which is an expensive program. It requires a very high fidelity monitoring, but time after time, in a number of different populations, when you have high fidelity to the model, you absolutely see fewer arrests, and that's over a 14-year time period. It's not 30 or 60 days after completion of treatment. We see a lot fewer violent felony arrests, and we also see a lot fewer out-of-home placements, because it really does go to the functioning of the family. And it's been a real game changer between our FIT and our MST in Palm Beach County, and helping better outcomes for families that, quite frankly, it would be easy to see or want to give up on them. And we've seen tremendous results when we put this in practice with the right families. Drug Abuse Treatment Association, our adolescent residential program provider, is responsible for this on the Treasure Coast, and Henderson Behavioral Health does the services here in Palm Beach County. And again, we, depending on where they are in the counties, we have access to both programs. And then this is just kind of an overview of the things that Southeast Florida is responsible for. So we're funding over 13,000 individuals in Palm Beach County. We do work on access, quality, and bringing evidence-based programming to Palm Beach County. And again, that's kind of the high level of just a lot of the different areas that we've been working on. And I know that there's a lot of emphasis around the opioid response. So at a future time, I'd love to go into a little bit deeper dive where we can talk about the things that we're providing, like the Sublocade, the long-acting injectable, our MAP program that's in the jail, use of methadone and expansion to a second clinic and more coverage here in Palm Beach County for methadone treatment, and then also our ability to provide incidental fundings for the sober homes and recovery residences, and our work in helping individuals while they're in that transition of really kind of getting on their feet, getting employed, and having that safety net to help them through until they're able to sustain their own recovery. Again, in collaboration with a lot of the work that's being done by Palm Beach County and John Hewlett's efforts to bring about the recovery centers. And so I think for me, 2024 is really a time to be optimistic. I thought it was awesome to see the reduction in overdoses here in Palm Beach County. And that was a great way to kind of kick off the meeting. And so I'm looking forward to more opportunities to go in more specifically. But I did want you all to have my direct number. I know I've talked with a lot of you. I know there's no one on this task force that's shy or bashful. So reach out and let me know if there's anything that we can do or in working with you. And so Al, I'm not sure how I did on time, but if there's any questions, I'd be happy to field them. Al, are you on mute or am I?
No, Al's muted. Al, we can't hear
Okay.
what you're saying.
Okay. And I know it's profound.
Let me just say thank you, Anne. We'll bring you back in 2 months to do that deeper dive. One thing I do want to mention is your housing vouchers require certified recovery residences, which is a plus.
Yes.
And I see that Jeff Lynn, you have your hand up, so go ahead, Jeff.
Yeah, I just,
Okay.
hi, Ann. Nice to see you.
Hey,
Quick
Jeff.
question, just for my own clarification, or for a lot of people here who aren't aware. As a basic statement, without getting complicated, is it safe to say that the entities, the treatment entities that fall under your umbrella that you oversee, are all of those government funded or get money from the government in one way, shape, or form, or is there any insurance involved? I'm trying to understand
Mm.
the distinction between an entity that would fall under your management and purview and then everyone else.
Almost all of the providers take Medicaid, and they also take other insurance. So United and Blue Cross obviously are the ones that come to mind. There's a few select ones. So when you look at that chart that I had on the residential programs,
Yeah.
where you can see the capacity, and so and there's a couple other pieces, right? So on that chart, you'll also see room and board. And so what happens is Medicaid will pay for the treatment aspect of it, but they won't pay for the room and board. So a lot of times it's a blended funding that we'll use. And so we want to be, obviously take advantage that Medicaid will pay for the treatment, and we'll cover the other pieces. But that'll give you some insight about the capacity and then how much we purchase.
Got it.
I think.
And do you provide, as SEPBEN, do you provide an extra layer of oversight when you contract with a treatment provider? In other words, do you actually go in and do visits and oversee some of these programs?
Absolutely, and I'm sure Alton could chime in and verify that is indeed a reality. So we do follow up on expectations beyond just the licensing level, and then we also, all of the areas that we fund, our information is is posted, so that if there is an issue or if there's concern about access to services, that we have the ability to go in and look at that and work with our providers to resolve whatever issues may be at hand.
And any providers that you use, are they required to only use certified recovery residences
Yes.
or Oxford House?
Yes.
Okay, thank you.
So and we do have that whole transitional voucher piece where part of the requirements is that you have to have a plan. How are you going to sustain it, right? Because we don't want somebody who hasn't gotten far enough along to know how are they going to be able to maintain their housing, because the last thing that we want is 3-4 months into it and they still don't have any ability to help pay for it. And so cutting somebody off, right, is going to throw it right back. So we work hard to at least have a plan. And of course, plans change, but we want our providers to be helping look at what is the next step and how are they going to continue to evolve on their recovery path.
Thank you, Ann. Really appreciate you doing this. Let's move on. We're going to reorder because we have some time issues with the next presenter. And I think this is fascinating. Getting police departments, police agencies involved in mental health, substance use disorder, and homelessness issues. And Riviera Beach has stepped up to the plate. Chief Coleman has an officer that's completely dedicated to the homeless population and those and the concurrent issues that are dealing with the homeless, like substance use disorder and mental health. And so she's going to do a brief presentation of a model program out of Davenport, Tennessee. And I'll give the floor to Jennifer Jones from Riviera Beach Police Department.
Hi, everyone. I just wanted to first say a lot of what I'm going to be talking about is what some of the stuff that Ann just talked about, which was very interesting to me. I learned about the Partners in Care program in Nashville, Tennessee, and it was sponsored through the Mental Health Co-op. So here is it on? Is it on? I'm trying to share it, sorry. No. Okay, good. So they also talked about the MAP program, which the medical assisted treatment worked very well for them, and they did motivational interviewing. So with that was, what I'm noticing is a huge increase in homeless people with mental illness right now. It has grown so much that it's almost to the point of you don't quite know what to do, because Baker acting is not, it's not an option. Like it's an option, but that's not the only answer. So we're seeing a huge increase in homelessness.
Change to policing.
And homelessness with mental illness and also addiction problems, because we all know that it goes together. And so the whole Partners in Care program and working with the mental health co-op, what they did was combine, it's basically what the healthcare district does, but with 24-hour-a-day care and beds that are included. So I think it's been, I can speak from a law enforcement standpoint, that it's been extremely challenging to try to help people that they get Baker acted and they're in there for 24, 48, 72 hours, and then they're right back out on the streets. And now they're off their medication. They don't have, a lot of them don't have insurance, and there's really, what do you do at that point? So what they do is they have licensed clinicians ride with the officers, and I believe Adriana and Del Rey would, you know, she knows a lot about this also, and being having a licensed clinician ride with the officers, what that was doing was allowing the officers to respond to these calls for service, but also having the clinician take over and do the assessment, and that clinician knows the best form of care for this individual. So that was a big eye-opener to me, because what happens a lot of times with road patrol is we get so busy and we ask them 5 typical questions, and then we end up Baker acting them, and it's just this whole cycle. We see the same ones constantly back out there, and we're constantly Baker acting them again. So it's really important, I think, to get people long-term help that they need, so that we can see not only a decrease in homelessness, but we can see a decrease in people with mental health out there not having a treatment plan and not knowing what to do. So I think that they started in Nashville. They started in 1 precinct. They have 8 precincts in Nashville. They started in 1 of the 8 and saw a huge decrease in the amount of arrests that took place with people with mental illness. And so then now they're in 4 of the precincts, and they plan on going to all 8. And what happens is there is a licensed clinician that rides, that's assigned to every shift, which is a tour of duty, which in most police departments there's 4, and a clinician rides with the officer. They get the training, such as wearing a ballistic vest, and there's a whole training program that goes with this. But then the clinician is able to help the people with the mental illness and determine whether they just need that short term, or whether they just need the MAP program, or whether they need something more of a long-term program. And then at that time, the assessment is done and it's offered to them. So again, it's a lot of what Southeast Behavioral Health was just talking about, and I think that the 2 together could be a great force for Palm Beach County, because right now I am friends with, and I've spoken to several different law enforcement agencies and officers or deputies, and we all feel the same way, is there's just not enough space. And unfortunately, these people are just not able to live their best lives because they're not getting the long-term health care that they need. And a lot of them are not even diagnosed. So we're seeing this huge increase of people with mental illness, and then they start using drugs, and it's just this vicious cycle that they're in. I was trying to share the PowerPoint with you guys, but I don't know what happened. So there was a video on there of them explaining. Is this? Can you all see the video?
Yes.
Okay. Are you able? No sound.
But not the volume.
Okay.
Audio.
Hey, good morning, Ben. Yes, we do. It's actually called the Co-Response Crisis Intervention Program, and 16 officers from those precincts and 6 clinicians volunteered for this first ever department program. And we're going to walk you through a little bit about what these changes and what you really can expect. Originally, the process would be officers called mobile crisis, and then they'd come out, but there was that little bit of that time gap there. And starting today, officers will stabilize the scene and clinicians will evaluate anyone in need of help. And this will go for the next year. And we'll have these clinicians partnered up during the day and night shifts, according to the department. And MNPD says they have 4 goals: improve access to care for those experiencing a behavioral health crisis, divert those in crisis from the criminal justice system to the healthcare system, improve safety for those in crisis, clinicians and police officers, plus improve coordination and communication across systems and service providers.
Well, with this, mobile crisis counselors right there with us. They're going to be riding every day with an officer who's been trained in crisis intervention, and they're going to be responding to those calls for service.
Police plan to expand the co-response model across other precincts after the program is evaluated. And when it comes to this becoming 24/7, only when it's expanded will they consider it. Reporting in Nashville, Cole Johnson, News Channel 5.
And here, as you can see, some of the statistics, some of the numbers, and it has been expanded to 24/7 at this point. So it's something that I feel like is very needed in Palm Beach County, because we need, when Jerome Golden closed, that really was detrimental because all of those patients that were going to Jerome Golden are now either homeless in Riviera or they're homeless in West Palm, or a combination of both. We have a lot of floaters, and we've seen an increase through PBSO jurisdiction. We've seen it's been a huge increase, and so it's really just figuring out a way. They figured out a way to bring everything together and become one unit. Like I said, it's pretty much Southeast Behavioral Health or the healthcare district, but just 24 hours a day, 7 days a week, with therapists and people taking care of and treating the mental illness instead of just a short-term Baker Act, because you can't just give somebody medicine for 3 days and then they go back out on the street, because now they have no means or desire to get their medicine, and we're taking the same person back a week later. So it is funded through, and Duval County, it's funded through the mayor's office and other organizations, and they've just seen a tremendous decrease in the mental illness and homelessness and the arrest rates. So that's what I wanted to share with all of you. And I'm sorry about you can see right here that Florida is ranked number 3 for the most homelessness. And we are actually getting ready to do the point in time count the 25th and 26th of this month. But I can tell you, just from last year to this year, there was a jump in almost 400 of almost about 400 people. And that's just the people that have been counted. It was roughly around 1,850 people for Palm Beach County. So, and the amount of children in schools, the amount of kids, and working with McKinney-Vento, and the amount of kids, and I've met with all of the principals at all of the local schools in Riviera Beach. the amount of kids that are experiencing homelessness and then depression, anxiety is growing at an all-time rate. So the hope is to be able to start a program like this, and all of us work together so we can start to see a decrease in those numbers, a decrease in the arrest rates, kids actually being able to go to school and not have to worry about being homeless, and people with mental illness being able to stop using drugs and get
the audience better.
I think they're changing wires, so I think they're changing wires. So the wonders of modern technology and AI.
Testing, can y'all hear us?
Should you come in here and use your computer?
Can you hear us?
Yes. Yes.
Yes.
Okay, is it still staticky or no? Or is it very light?
It's good enough. We gotta get going. So it's a little
Okay.
better than before.
Okay. So all right. Let's max out. Okay. Go.
Okay, so, again, I apologize. I wish that you could have all seen the entire PowerPoint, but, just looking at the numbers, and I went up there and I learned about the program, and I actually rode with the clinicians and I rode with the officers, and it was absolutely incredible to see what they do. And mind you, those officers, they don't respond to other calls for service. They strictly respond to whether it's homeless, mental illness, somebody that's living in a residence or a business. They strictly respond to mental illness calls with the clinician, and then they help those people. And when I went to tour the facility, it was just fantastic. It was basically the healthcare district, or Jerome Golden. Jerome Golden is a perfect example because it did have the beds, it did have the different therapy rooms, it did have all of that. So just to still have that building that's sitting empty, to me is a great opportunity possibly. So I think just being able to talk from a law enforcement standpoint and say, like, this is what we see on a daily basis, and the number is growing. It's definitely not decreasing. So I would love to answer any questions if anyone has any questions. And I really, again, apologize for the difficulties, and thank you for your time.
You go ahead and take that off. Okay. Any, unmute. Yeah. Any questions? I know, Ariana, you've been doing some of this. Do you do ride-alongs as well?
So our unit follows up on every Baker Act. So what we're doing is not riding. I mean, we have 2 officers in our unit that we're riding along with all day. So if something comes up, we go along with them. But otherwise, every single Baker Act that goes through the police department, we follow, we review all the reports, and then we follow up with the person, visit them at their house, see if they need any follow-up, connection to services. Even we offer to drive them to their next follow-up appointment to get their meds. We advocate for them to get their meds paid for. Like, so we do a lot of, you know, outside of the box stuff.
Okay, and for those of you who don't know Ariana, she's Delray Beach. What is your title?
When they hired me, they called me the service population advocate, so I went with it.
And your clinical bona fides are?
I'm a licensed mental health counselor and certified drug and alcohol counselor.
Okay. And I can tell you over the years, Ariana has saved many lives in Delray Beach. And you know, between all the different factors, not only the police department, but also code enforcement and various citizen groups, they've made great strides in Delray. I don't think you have a program name, but
well, we're the community outreach team.
Okay, community outreach team, and other than not having the beds and maybe quite as many personnel, it's a very similar program that you have than the one in Nashville, Tennessee, I would think.
We all got to do what we got to do in our county.
Right. Lissa, you have your hand up. Lissa Franklin, go ahead.
That's for me. It's Rachel.
Rachel,
thank you,
hi.
Lissa. Hi. Thank you, Lissa. I couldn't do it. I guess I'm trying to understand, and Ariana, what you said kind of, you know, answers a little bit, but, you know, I think obviously the program is amazing and it sounds great. And I'm just realistically, I'm trying to understand how they get services and on an ongoing basis. I mean, I know I've called in every favor, bought every lunch that I can, and I can't get somebody in to get help with meds or anything for at least 3 months, if even that. So I mean, is this putting a Band-Aid on, or is there a way to expand services, make sure that it's more long-term? Ariana, you mentioned visiting them at their houses. Many of them don't have houses, you know, and might be jumping around from place to place. Like, plan for something that's more sustainable than just crisis intervention and getting them in that moment.
Right.
You know?
Go ahead.
And that's what the program in Tennessee does. That's what the Partners in Care program does, is because you have to assess everybody differently. And it's like you said, like, you know, you scramble to try to get continued help. And this program is continued help. So that's why I loved it so much and thought that we needed to bring it back here, because you can release that person and you don't know where they're going. Are they going back out to the street? Or you just don't know. So it was the clinicians are provided in Tennessee. The clinicians are provided through the mental health co-op there. So it's a whole system, and the dynamics, the way it works, it flowed very well, and a significant difference from year one to the end of year one to year two.
So we don't have that yet in West Palm, is what you're saying. I might have missed that.
Correct.
Oh, okay.
Correct.
Yeah. I mean, yeah, that'd be amazing if we, you know, there's literally almost nowhere for people that don't have money and especially don't have shelter around us to go.
Correct.
Yeah.
And then you have the crime rates that are increasing, because now you have, you know, it's all of the, and Ariana, she can, I probably agree with this, is very much, it's constantly a lot of the same people that we're dealing with. And, you know, when they're off of their meds, theft goes up, so much stuff goes up, and it's the quality of life that individual is living is not the quality of life that they could be living. And we just need something in Palm Beach County that is like the Southeast Behavioral Health is great, and it's everything that they offer at this program. It's just 24 hours a day. the healthcare district is phenomenal. We need something that is 24/7, that offers beds, and it's for Palm Beach County, and Broward would have one, St. Lucie County would have one. So you're not having people scramble from all over, bringing someone from Broward to a bed in Palm Beach. And it's just, the system works very well there. And I have all of the articles and the links. I can send it to whoever is interested. But when you learn about this program and the flow of it and the amount of people it's helped, and the decrease in mental illness, addiction, and arrests is pretty incredible.
Jennifer, one question regarding a lot of what you're talking about is the crisis stage, say the first several days or beyond. Number one question is, how many beds are available in the Nashville program? Number two, is there any part of the program that deals with the longer term housing issue? Because again, everything you said is spot on about if you don't have a place to live, you're back out on the street. But you know, how do they deal with that in terms of the longer term?
Correct. And so what they do there is that the person is set up on a plan. So when they're being released, then they go into like transitional shelter, transitional housing. They're not released back out on the street. So it's everybody on this call, like it would be all of us working together, and that's pretty much what they ended up doing there. And it's pretty incredible when you bring resources together and say, okay, like Southeast Behavioral Health has this many beds and this is what they do. And so to answer your question, yes, they are set up on a plan. Now, say if they were brought in for a crime, like they did petty theft out of a 7-Eleven, and because they are considered with a mental illness, then they are put on a plan to take away that misdemeanor, right? So we don't want to just keep charging them with misdemeanors. We want to help them get better. So yes, after whether they're there for 72 hours, some of them, when I was there, some of those patients had been there for 2 weeks. But then they go into transition, whether it's a shelter, if they don't have a place to live. If they do, then they are released back home. However, they have to follow a daily, they come in, they do their treatment, they get their medication. So it is the MAT program, which is the medication assisted treatment. They talk to their therapist or the clinician, and that's how they've seen the positive outcome out of all of this.
All right, thank you, Jennifer. Any other questions or comments? Okay, let's move on to the last presentation before we get into this, the legislation discussion. And that's Dr. Courtney Phillips. And congratulations, Dr. Phillips is back with the Palm Beach County Healthcare District, and she's going to talk about the healthcare district's implementation of the Crisis Now model in collaboration with the other community partners like Southeast Behavioral Health Network. So go ahead, Courtney, you're on.
Hi, everybody. It's great to be back. It's nice to see a lot of faces. Can you see my PowerPoint?
Yes.
Okay, perfect. And let me put it in presentation. Can you see it in presentation mode?
Nope.
Nope. Let me share a different version then. Hold on. There we go. That better?
Yep.
Okay. For those of you, I know a lot of you on this call, but for those of you who don't know me, I'm Dr. Phillips. I'm a board certified addiction psychiatrist. I've been with the district since 2017 in some capacity. The last year I had the pleasure of working with actually Secretary Harris and her team on some of what rolled out with the state because of Palm Beach County's model in collaboration with other community agencies. And I also had the pleasure of working at Wayside House, which is a DCF supported agency that does wonderful work thanks to what Seth Ben and Ann Berner do. So I have the pleasure of having so much experience seeing the wonderful things that you all are doing. And there's many of you on this call that I've worked with in other capacities. So it's nice to be back. I'm coming back as Vice President of Behavioral Health to continue to expand behavioral health at Healthcare District. in the substance use side, the therapy side, as well as the psychiatric side. So it's an honor and a pleasure, and it's nice to work with all of you. So I'm just going to do a quick update. We're going to go over some current services and future plans and collaboration for Crisis Now. And it goes along a lot. It really parlays well with what Anne and Jennifer spoke about. So there's a theme here. And it's nice to see the whole county coming together, because I know living here and working here, when the county comes together, we can do anything. So it's great to see those presentations. And as a physician myself, I do access a lot of the services being discussed for my patients. So it's great. Just a couple things for the substance use disorder services. A lot of you guys understand what we have been doing at Mangonia, but I do want to reiterate here that we took the Mangonia Park site that did the primary share of our substance use services, which is on the JFK North campus, and we've duplicated it in our Delray Beach site, October 1st. It offers all the same substance use services, including mat inductions, tapers, outpatient treatment for alcohol. All of that stuff is in the Delray site in Congress Avenue. So I know Ariana's on the call, but we will see people, and we have a lot of capacity there. So if you have people in the South that you need services for substance use care, we do the exact same thing down in Delray that we do in Mangonia Park now. And we have primary care there, psychiatry, group therapy. We have a lot of capacity for psychiatry, actually. So I'm going to talk about that a little bit at the next slide when we get to it, and I'll speak about that. We also have a lot of capacity for the substance use services, both at Mangonia Park and in Delray. Please call us at 642-1000 to make an appointment. I'm gonna go out on a limb and say I understand that we haven't always had the best call center, but we've improved it quite a bit. And there's initiatives to make sure that those patients end up on appointments, or the patients can just walk in. We want them, and we want to take care of them. We've built a lot of capacity for these patients. I also want to point out that the one thing that we are moving towards, and this is something we're dedicated to doing, it's going to happen, is we are going to make the Mangonia Park Clinic that was mentioned, that does a lot of things from 8 to 5 for patients who need help right then and there. We're going to expand it to 24/7. So we're looking to do that in the second or third quarter. So I heard somebody on the call saying we really need more 24/7. We want to be that receiver, and it is going to function as a regulated clinic. So it will be an overnight clinic. So it's not yet, or it's not at this point, or not going to be in the near future, a 24/7 Baker Act receiving facility. But we're starting to work with police departments locally in a pilot to try to see if they would be willing to bring people if it's on the fence and they don't know, and let us see if we can divert it. We're going to have medications there through a Pyxis, so they won't need to be prescribed, even though in a clinic they usually do. We'll be able to offer medications right there, including buprenorphine. This will also take care of some of the changes that have occurred at the JFK North ASU. The JFK North ASU has been a wonderful partner for many years. They've had to change their services to a service line, which was different than what was originally built. And it was more of a unit. So we are going to receive all of those patients. They're going to be comfortably kept to the warm handoff to the daytime clinic, which will be right there with us at 8 o'clock. So I've come back on board to really help with that. We're very excited about it. And we want to start to build rapport as well with police departments, mental health court, drug courts, to continue to have this place for people to go long-term, to receive substance use care, psychiatric care, therapy care, care coordination. And then I want to talk about our SFBEN collaboration, which I'm really excited about. Grateful to Anne and Linda Kane for helping us start to work on, where we're going to be able to give the vouchers, because one of the things the district, we're really good with medical and psychiatric, but we could use some help on the social side. And we know social determinants of health in the literature are such an important part of care. So Anne and her team is working with us to develop a contract so that we can work together to get those patients vouchers. And I'm excited about this collaboration. It's still not finalized, the contract, but it's going back and forth. And I'm very hopeful that our clinic teams can, start to participate with the DCF family. As I think if we work together, the sky's the limit for our patients in the community. And then we're also using the injectable buprenorphine as an added MAT through insurances and through the grant. Okay. In terms of our integrated behavioral health program in primary care clinics across the 10 clinics, we are working on pediatric integration in the Lantana clinic. So what does that mean? We're looking to have a social worker in the pediatrics program to start doing warm handoffs and address mental health needs for teens. We've also added a social worker in a bunch more clinics in the adult primary care, including Belglade. We had lost somebody for a few years. And we have them in every clinic except Boca and Jupiter. Boca and Jupiter have remote coverage, but St. Anne's, West Palm, Lantana, Delray all have their own social worker. So even people coming to primary care can get some light mental health care. And then we're adding more individual therapy. We're working on that as well. That's been a gap for us, as well as still referring out. On the psychiatric side, we have a lot of exciting things to report. So FAU and Healthcare District, we are now taking all of their residents in their 3rd and 4th year of training in Delray and Mangonia. So 4 days a week, every day but Wednesday, which is their didactic day, we have 2 residents at each clinic with an attending. So we're really starting to develop some academic partnerships, which is a wonderful, wonderful resource for our patients. And it's a wonderful training ground for the residents. It will also, I think, keep us relevant and current with best practice as education departments keep us relevant. We have moved a psychiatric APRN to our Lantana clinic full-time to cover the middle of the county. And we have a full-time psychiatric APRN in the West Palm Beach clinic. That's not Mangonia Park. It's down on 45th Street on the health department building that's right across from St. Mary's. So both are trained in the MAT and substance use as well. So now at this point, we have 4 clinics that have full psychiatric support all the time. So we need, actually, I was just looking at the schedules and they're somewhat empty in Delray mostly, as well as Lantana. And we need and would love to have more of your mental health patients come during the day. We're seeking, regardless of their ability to pay, insured, uninsured, we will see them. So please take access that resource as we've had it. And I just wanted to get the word out there. And most patients can get seen fairly quickly within a day or a week. So I know for right now, we have capacity for very quick follow-up. We're also working on getting in injectable antipsychotics as regular practice. And with the residency program, working on eventually things like clozapine and things that are dealt with more CCBHC stuff. So let's talk about the future plan. And I see Jeffrey, you have a question you want to ask now? Jeff Lynn?
Sorry, I had to unmute. Hi, Dr. Phillips and everyone. I just heard, like, I'm listening, just so you know that I'm listening to you very carefully.
Mhm.
I just heard like a passing comment that the ASU you didn't say this, but like it's closed, for lack of a better word.
No,
I know you didn't say that, but like it's like we're facing patients that are like, whoa, what happened to the ASU?
So there was a lot of discussion with this. It's still there. It's still functioning. It treats people with MAT 24 hours a day. But just to be clear, the healthcare district, we're a separate agency than JFK. That's an HCA hospital. And due to their current situation, they're mostly doing a service line. What does that mean? When you go to the emergency room, it's a general place where you get GI services, you get addiction services. So they're in a general area of the ER most of the time. And it's treated like any other illness. Like, hey, you've got this person in this bay has a GI issue. This one's got a substance use issue. And I know the docs over there, they do the evidence-based medication treatment for those patients. Originally, they would keep people till the morning to sort of hand them off. And that has sort of adjusted over the last year due to factors with HCA. So we are hoping in the second, third quarter, when we open this 24/7 clinic, we will be the ones, we would like to keep them and keep the original intent of the model, which is to keep the patients overnight to get them to that morning bridge program. Does that make sense?
Yeah. So what's happening now is I don't mean to use this colloquially, but are they being treated and streeted, for lack of a better word now?
So what I would say, and also with my work with the state, they're getting much better treatment than most ERs. Only 3% of ERs offer MAT still, and that's been a very hard thing to fight for some reason. And now, I think we still have the data, and Al asked me to show that at the next meeting, but something around 50-60% of the patients get the MAT, meaning they probably wanted it and they received it. So there's a high rate of evidence-based medication prescribing, but are they keeping them all night? It's not, that part is sort of going away. And in all fairness, I think it's a time that we need to step up as well, JFK was a great resource for a long time. It's time for us to be that public option and really do what's right, because we have the resources to do so between healthcare district and hopefully South Bend, so that we can, the ER will still be there. The ASU will always still be there, because medically compromised patients who need to be monitored after an overdose have to be in a hospital, right? So we have a good relationship with them. It's just, I think things are sort of evolving in the county, and they are going to continue that unit. They've said that they will, while we're kind of building this 24/7 clinic out. Our clinic, most of you have been to, is very large. It has a lot of comfortable space, and we're looking at expanding that a little bit as well, to have a police drop off as well as patient walk-in access. So yes, does that clarify your question? Okay, thank you. So Crisis Now is a model, is a term coined by, well, let's just talk about what's currently happening, right? There's so many good things happening in Palm Beach County. And I think that Anne talked about it, and Jennifer's talking about it, and I know Ariana's doing it, and I know a lot of the individual players, but again, making sure that I know that we will get this right when there's a day when people don't call me to ask me what to do with someone they love in a mental health crisis. None of my family and friends call me when their partner is having a heart attack, right? They know what to do. They call 911, they go to the ER, and then they call me after. And we need the same thing for mental health, but to the point of somebody on the call, there also needs to be an extensive system of somewhere for them to go. So you guys can read this slide, and when we have these breaks in the coordination of the system, then we get homelessness, unemployment, social isolation, and lots of problems, right? And we get a lot of overuse of the psych hospital. So why did a healthcare district get involved with this? There was a lot of discussion with Palm Beach County administration. And I think that when we learned a lot with the substance use build out, we also felt brave enough to sort of take this step as a team, as well as becoming more familiar with all the community agencies involved. And we reviewed the SAMHSA guidelines. It's called Crisis Now, National Guidelines for Behavioral Healthcare. This is a best practice toolkit. Everyone can access it if you want to. We ended up contracting with a group called Initium. They're a public benefit corporation, and they've been spending the last 6 months just assessing Palm Beach County with all of our partners to see what we currently have and what would bring us to the level of the guidelines, as well as help improve all the coordination. So an outside agency who's done this in multiple counties actually to help us. So that's what Initium is. They presented, they said their final report is ready. It's still in draft and not available. It will be available for everybody as soon as the results of the December 19th meeting that combined all the community partners comes together. So they're going to put those findings in their report and also follow up on some things that were discussed in December 19th. That will be accessible to all of you, but I did have Al and Mary send you the executive summary. That is for public record at this point. So the idea of the 4 core elements are the high-tech crisis call centers, which Anne spoke about, 211, and potentially doing 988 and starting to divert 911 calls that are primary mental health. But the high-tech crisis call centers also incorporate really interesting technology that is able to track all the mobile units, all the beds in the area, as well as all the outpatient appointments available with the different agencies. So the IT component is very important, so that someone on the phone calls and they could say, hey, we think you can wait till the morning. You said you can wait, it's 2 a.m. There's an appointment at 9 a.m. at such and such place. Can you make that? And they can schedule it. So there's things like that with the technology that would coordinate all these agencies that are doing great things, but sometimes need to coordinate. There's 24/7 mobile crisis, which Anne spoke about. There's the 3 through South County, and I know there's investigating about the other ones in the area. But per capita, it sounds like if you go to SAMHSA, there's a calculator that says based on our population, we need somewhere around 21. I know there's police involvement in starting to look at mobile crisis units. There's the ones through South County, there's the ones through Ann, so that's being discussed. And then a crisis stabilization program, which essentially is a place to go so that people don't, if they can't resolve on the phone and they can't resolve in the mobile crisis, there's a place for them to go. This essentially is a psychiatric emergency room, which is an evidence-based model to try to treat people without Baker acting them, try to resolve the issue in a 23-hour stabilization. And many counties in Florida already have this stuff. Broward is one of them. Henderson is very impressive in this way. Miami has it, and they have very good relationships with their mental health courts. But we have parts of this here, but we still need to probably rise to the level of the guidelines. And then, looking at essential principles and practices, all of this can also roll into substance use. To me, and to us, and to our mission, substance use and mental health need to be addressed similarly in terms of these systems of care. So someone to call, someone to respond, and somewhere to go. And per SAMHSA, right, this is per SAMHSA and some evidence-based papers, if you have it set up properly, 80% of people calling are resolved on the phone. Once they send out a mobile crisis team, you can resolve up to 70% in the field. And of those people left over, 65, if they get to the crisis receiving facility, can be sent to the community. And then the other 85% can, remain stable in community-based care, which Ann spoke about as well. And we want, there was a lot, I'm repeating myself, but we wanted to have easy access for law enforcement, connection to treatment instead of arrest, and to stick with the least restrictive option. As we all know, Baker acting somebody is very, very distressing. So this is just another way of discussing this with more specifics from what the healthcare district has. But like I said before, the only thing that the district is committed to at this time, outside of hiring Initium and having them assess and having these roundtable meetings with a lot of the partners who have elements of this, we are only going to expand Mangonia Park to 24/7. Mostly we were to really assist the ASU to combine with them and build that model, as well as to start entertaining what it would be like to receive these patients in a public entity all the time, even though we can't restrain them, and it's a clinic and things like that. And the somewhere to go, and then the other thing is, we talked about someone to call, the people, place, and purpose. Anne spoke a lot about this, and she's so right. And I would say, I've always been in awe of Wayside and some of the places where they get people well who are very difficult. And it's because of this. They get them housing, they get them sustainable situations that they can live in. And kudos to SFBEN for, I saw the housing statistic, 90%. That's really great, especially in this market. So this is a cost comparison for crisis now, if you're in a county that absolutely has nothing. And that's, so I want to make that clear, that crisis now, if you look at the model and how we would do it, it would be about 138 million. And if you go with the old model where it's send them to the emergency room, medical emergency room, it would be about 281 million. Now, there might be more of a closer number, not so far to 281, because we do have some of the services now. So this is not based on Palm Beach County. This is based on overall assessments from the model. So where are we now with this? Initium completed their feasibility study. They have a full draft to be finalized based on the community meeting from December 19th with some follow-up that they're doing. And the executive summary was sent to you all. We've committed to making the Mangonia Park clinic site a 24/7 designated clinic. I'm hoping, we're hoping for Q2 or Q3 implementation. It's really, I think the staffing is the thing I'm most distressed about, to try to set this up, trying to make sure we can staff it properly. And this will also help patients diverted or cleared from ASU, as well as give Crisis Mat to do a 24/7 warm handoff and keep them in our clinic so that we can start working on the other parts of their care in the morning and attempt to prevent Baker Acts. We're exploring collaboration in many ways to help lead elevating standards of current systems for just different aspects of the systems, as well as potentially taking the lead. But we're still in a lot of conversation and openness in terms of maybe somebody in the community should lead a part of this and we should support it. And what's the data that we're all going to agree to? And what are the outcomes metrics that we all want to follow? And is there an IT solution that we want to share together? I think where the district stands is that we just want to make sure that we all level to, the level of the evidence-based model that has been presented to us and that many counties have successfully implemented, so that we can be, hopefully not number 3 on that map that I saw. We can rise a little bit. Okay. And that's it. Questions? I see Houston, you have your hand raised.
Yes. Hey, Dr. Phillips, thank you for that presentation.
Sure.
This is really kind of a statement to the whole group. Dr. Phillips has done some amazing work across the state. And I want to pay tribute to it all coming back to what was initially established in Palm Beach County as the model. And with the Department of Health taking on the initial 12 counties for MAT assisted programs with EMS and behavioral health providers, it has transitioned to DCF. And their goal right now is to bring on another 17 counties, with eventually all 67 counties meeting the same standard. But a couple of things to add to that. Dr. Phillips, you mentioned a couple times about Baker's Act, and I would ask that maybe we consider also the Marchman Act, because quite frequently we interacted with patients that were under Marchman Act orders through the magistrate. And then if we could coordinate some efforts with the magistrate to provide support for individuals that are being placed under the Marchman Act within that 10-day window, they've been pretty receptive to not necessarily forcing the Marchman Act, provided that the individuals get into a MAT service program or opioid use disorder treatment program. And I think that would actually alleviate a lot of the backup and unnecessary Marchman Act emplacements.
I think that's a really good point, Houston. I'm glad you brought that up. And we often forget about the Marchman Act, and that needs to be part and parcel with the Baker Act, right? We need to address both. So thank you for that comment.
Sure. And then just one other thing I wanted to add is that Palm Beach County Fire Rescue has kind of taken a different approach to what was originally the model for the system that was created. They're utilizing their EMS supervisors across the county to respond to opioid use disorder type events, and where they're being involved with pre-hospital induction of buprenorphine and kind of getting the patients into the right direction. And then also under the direction of Dr. Shepke, he suggested or has implemented a change in the dosage of Narcan for pre-hospital settings by a EMS provider. And this is fantastic because we're taking away that mindset where people have been given really high doses of Narcan, which puts them in acute withdrawal. And it's now being dialed down to a much lower dose, and where it's just maintaining the person's ability to breathe, and then a smooth transition into the emergency rooms for better definitive care.
Awesome. Thanks, Houston.
You're welcome. That's all I have to say. Thanks.
Any other questions or comments? Well, this has been great. We've had some great presentations here, and we're moving in an incredible direction this year. So I want to thank everybody who presented. Now we get to the sausage making known as legislation. There's a couple of things that I think are going to have quite a bit of input. At the request of some of the legislators, some sections were added, and we're going to discuss those. Also, Jeff Lynn had an issue with the wording of the I'm sorry, oh, this is the House bill. It's not in there. We're going to be using the Senate bill as for the discussion point. I think it's the most accurate and inclusive. Needs the least amount of changes. Yeah, Jeff had a question about community housing and how it's dealt with in this proposed legislation. So first, we're going to look at SB 1180. And actually, the first one we're going to go to is on page 4, actually page 5.
Hang on.
Yeah, that's it, community housing. This was put in a different section in the House bill. I think I know why. I think that committee staff is looking at the fact that there are so many numbers in the definition section of 397, 311, that if you if you add a 9 and then 9 goes to 10 and everything through 50 goes one number down. So wherever that stuff is mentioned in legislation, it's got to be amended. I think they have a way of doing that where it doesn't have to be in the bill, because then the bill's 500 pages long. But I think that my opinion is it's best to have this community housing definition, because it's a new concept, a standalone in a definition. And Jeff, I'd like you to explain why this definition is needed. And what's the goal? What's the end goal? I think you had mentioned to me something about insurance payment for certain items that they're not paying for now. But go ahead and give us a thumbnail on why this is needed.
Yeah, let me if you can just for a second, I don't know if you can make the screen bigger. Scroll up really quick first to the 4 levels of FAR right there. That's good. Actually, right
Level
there.
4, right?
Okay. So what we did this year, we talked about this in the task force, was to articulate in state statute what the FAR levels of support are, because they don't specifically match NAR, the national standards. So, and one of those things was to define, the most important thing we felt was really to make the distinction between a level 1, 2, and 3 on one side and a level 4. A NAR level 4 is the equivalent of inpatient treatment, which we know we don't have as a FAR level of support. So we had to look at what does FAR want level 4 to be, and that's where this definition came up. And it talks about a certified recovery residence where essentially it's treatment driven housing as opposed to resident or patient driven housing. And so if you are providing housing as part of your IOP program or day night with community housing, if you're providing that housing and the people have to live there, that's a level 4. So great. So then we wipe our hands of that, and then we scroll down to community housing. If you could scroll, the reason now we created this is because that was just a definition of what level 4 is. This then definition says, okay, no matter what anyone calls anything, if you have that kind of treatment directed housing, and therefore it's going to be community housing, and it's going to be a level 4. The reason we have these two sections, it seems duplicitous, is for 2 reasons. One, we wanted to start getting into statute one way or another, the concept of the verbiage of community housing as being intertwined with treatment programs. That is how insurance is treating it in some parts today. Insurance is constantly evolving depending on who the insurer is, whether it's on the federal exchange, whether it's that kind of, for lack of a better word, Obamacare policy. It really is all different. But what we started to do is we wanted to start getting the concept of community housing, meaning housing that is tied to treatment and must be there for these people in recovery, to start putting in statute. Because once we put it in statute, then the next step will be to start making assertions to insurance is, hey, this is recognized by the state of Florida. This, what we all called the Florida model, which we've never put down into a statute or code. So we are codifying, or we're making a statute to recognize the Florida model of treatment as a modality that exists. We can't put our head in the sand anymore. It exists, and we hope that insurance companies, through doing this, we can keep building upon this. So ultimately, that at least some forms of housing tied to outpatient, where insurance is directing most of their patients. They're, inpatient, if you're lucky, you get an inpatient, but most, if not majority, of the medium to longer term care is in these outpatient modalities that require housing. So again, part of this is to get insurance to start recognizing it. The other side of this is that there are, in the past, when FAR was getting started up, and there were not clear delineations on the levels of housing between 2, 3, and 4. People were kind of at FAR, were kind of winging it, doing their very best. But what's happened since then is there are a number of housing providers in the state who were identified as level 2, and a level 2 is sober living that has a house manager. Someone's overseeing it. As I say loosely, a level 1's like Oxford House, a level 2's sober living that's sponsored, someone's managing it for you. A level 3 is similar, except those people can go to treatment, but they're not required to. And level 4 is treatment housing. So we want to call all of that community housing. There are those providers in the state still who were level 2s, and FAR said, you know what, a mistake is made, you're really a level 4. You need to upgrade, and they don't want to. And the reason they don't want to is because a level 4 requires more staffing. It requires more oversight. You're dealing with a different population, and which is why FAR is adamant that those types of providers must be level 4 providers. So rather than getting into an argument with those providers that they're grandfathered in, or that's not fair, or this or the other, the goal of this also is to be able to point to statute and say, look, this is what the state of Florida wants. Whether you like it or not, doesn't matter. Whatever we've said as far in the past doesn't matter. There's no grandfathering. You're a level 4. We'll work with you to get you up to speed, but don't browbeat us. Go browbeat the governor if you don't like this law. So those are the two parts of it. Is one, to start getting this ingrained into insurance speak, and two, to make it clear that a level 4 level of support home is different than a 1, 2, and 3, and FAR is going to very zealously adhere to that because of the oversight that we all believe needs to happen in those residences for the benefit of those residents.
If I could put a fine line on this, is what you're saying in essence, a level, an IOP or a day-night with housing or a day-night without housing, if a patient is required to live in housing while in treatment, it's then a community house. Is that what you're saying?
Yes, and a community house is deemed a level 4 level of support,
Okay.
and therefore they have to meet those standards.
Okay. And before this, a level 4 would only be the day-night with housing.
Correct.
Got it. All right. Anybody have any comments or questions on this? Now I want you to go down to page 10. Because I know in a conversation we had earlier that you were concerned with lines 288 to 290 or 288 and 289 in the Senate bill.
Yeah, right.
Notwithstanding
I
paragraph
don't think
B.
this first sentence it means what it means to say. Right. A level 4 certified recovery residence with a community housing component doesn't make sense. It should be
It's
a
not-
licensed service provider with a community housing component. And we've just defined community housing. So that's what I think it was intended to mean. Because that doesn't make sense.
Well,
A level 4 is going to inherently be community housing under this new definition, and vice versa. They're
well,
going to be
wouldn't it be then a community housing component, which residence is actively managed by certified?
That's fine. That's fine too. Yeah. I'm saying the
Because you
first,
wanna-
the level 4 certified with, that doesn't make sense, right?
Yeah.
It doesn't. Yeah. So either or, you could
What it is,
either have
what I think you're saying is it's redundant.
and confusing. Yeah.
Okay. Because you can't be actively managing more than 100 residents unless it's well, what was a level 4, but now would be a community housing.
Which is going to be level 4. I mean, the thing is, all level 4s are going to be community housing under the new definition. They're going to be, the two terms are going to effectively become interchangeable in Florida.
So really, actually, this is just, other than the fact that it's redundant, it doesn't change anything if you leave the language alone.
The only concern we have is that when you say with a community housing component, we're just concerned that people at DCF or others are going to say, well, look, that's what's written there. The legislature put that in there for a reason. What does that mean? And we start getting into debates over what that's intended to mean.
Well, in the context of community housing definition, it would, a level 4, a community housing.
Well, you could say level 4 certified housing recovery residents serving as a community housing component, replace with serving as or acting as, or
Acting
because
as, okay.
I mean, you have level 4 with. It's like saying it's with. It's like apples and
Okay.
oranges. It's not with. It's the same thing. That's the
Okay.
only comment I have on that.
I think, okay, acting as, all right. Any
Okay.
questions, comments on this? We have a hand, Micah.
Yes, just one thing on the oversight piece too is the integration of recovery capital indexing as part of that that oversight. That way we have ground up level for participant input on that. So looking, I mean, that's what we're doing here in Palm Beach County, and so as we look across the state, certainly looking at that as part of that oversight. So just wanted to add that in.
It's just a matter of whether we're going to mandate something to the entire state
Right.
Or just it's kind of practice. Sometimes I'm not really sure you want to add.
Oh, no, this isn't an addition to. I just want people to understand sort of where we're leading from Palm Beach County. It's not going to be integrated into this legislation at this point, but as we look down the road, that's going to be one of the critical indicators of this specific component is how we measure and get those outcomes.
Okay, all right. And Lori, Dr. Vinicor, you have your hand up?
Yes, I have a question. How does this compare to the community residential home? There's already a definition for that in Florida statute, isn't there? I'm just concerned that this might get confused with the community residential home, which is also dwelling units licensed under the Department of Children and Families.
That's a different statute completely. That's chapter 419.
Yeah.
It's entirely different.
It is.
Yeah.
It's a different statute.
It's
completely,
entirely
but
different completely. No, but the definition
Yeah.
doesn't travel. A definition doesn't travel in Florida statutes beyond the statute it's in or the chapter that it's in.
Well,
So you can't look at definitions in 397 and say, well, they apply to 419. They're isolated. They're completely different.
Yeah, the only time that would be an issue is if there was only one definition in statute and you had it referenced in need of, but because there's two separate definitional sections, they will apply to the individuals. In this 419.
Okay, that's great.
Is going to be that's the definition of a residential home, and then 397, this is a definition of community housing. So there's not
Great, thank you very much.
You're welcome. Okay, now let's flip back to, and this one's probably gonna be a robust conversation. Page 5, starting with line 127. Now I'm gonna put this up on the screen at first, just so everybody knows, okay, this is the one that's filed right now. And I've got some input from various sources that the intent of this was to be transparent and to make sure that the department was doing its oversight job and informing the public so that there was easy access. I've been getting complaints for years that getting public records out of the department is if it's not impossible, is very, very difficult. And it takes a while, and records have been sent out that were incomplete. I said earlier, and I hope that Secretary Harris is still on this call. We had a great conversation, and it is her intent to get things up on the website so that people can see what the department is doing. These are public records, but I also understand the position of some in the industry that if you wind up having like a star system like you do on Facebook, you're going to wind up having enemies putting bogus complaints up, and the complaints are unfounded, but they're still tarring the service provider, and I get that. I get the fact that unproven or unfounded complaints should not be highlighted in such a position on a website. But again, I was very encouraged that it is, before she came in, the Secretary Harris had in mind to beef up the website and have more information available to the public. And so now I'm going to put I did some slicing and dicing in view of the complaints about the unintended consequences. So we're going to put up, the lines are going to be different, obviously. And it's redlined. Hopefully it's legible. Yeah, there we go. Oh, yeah. Okay. This doesn't actually have the red lines. Can we get those, you think? So that you know what was cut out and what was, let's see if we can do this. And then we can have a robust discussion about what's good, what's bad, what everybody's opinion is. And I'm sorry, by the way, of getting this to you so late. But the bills were only filed over the weekend, so I couldn't get them out to you before yesterday. Or Tuesday. All right. We'll just have to go with the one without the red line. So this is the way it stands now. All right. And let's just go down this to see what people's opinions are. Oh, there we go.
There we go.
Prominently display line 5 on this. Okay. Make available on its website. And again, we give till January 1st, 2025. If there's more time needed, we can expand that. All information, including but not limited to information contained in the department's provider licensure and designation system pertaining to the following. Okay, A, service provider applications for licensure and license renewal. Anybody have an issue with that? Okay, B, policies and procedures provided to the department by an applicant for service provider licensure or license renewal. I think that might be in the Senate version in that language. But anyway, again, policy and procedure manuals that are required. Okay. C, the name and location of each recovery residence engaged in a referral relationship as required under the 2 statutes. It's there. It's a public record. It's on the PLAD system. And I think it's critical because I don't think there are enough resources and I'll find out during session, but there isn't enough resources. Plus, the department is not directly involved in the housing, except for when the referrals are to non-certified recovery residences, then they can administratively fine for the violation. And the only license that they involved in housing is day-night with housing. So everything else, all the IOP providers that refer to recovery residents, the day-night without housing, the department, rightfully so, says that's not our job. Our job is not to investigate what we're not licensing. FAR will step up to the plate, and that's what they do. So FAR needs this information, and I think the public needs this information because if they're going to send a loved one from Toledo, Ohio to a provider, they need to have easy access to make sure that the house that the provider uses is certified. So that's the reason for that. And any and all comers, what are your thoughts? Good, bad, unnecessary?
Al.
I see Susan Ramsey, you have your hand up.
Yes, sir, I do. And I know, I understand there are 2 sides to this in terms of whether investigations without findings should be available.
No, that we haven't gotten there yet.
Okay,
We'll
well,
get there.
if we're gonna get there. More importantly, I can speak from my own experience that I shared with you. I have a chart. The ability and inability to get this information about licensed substance abuse treatment providers is confounding. It's astonishing to me. So, we went from requesting them and we would get them within, a month or so, and maybe we wouldn't get all parts of it, to completely ignoring us, then requesting that we pay for copies, which I'm happy to do, and still not getting the information. So I can tell you from license file, when I request a complete file to the next one, you don't always get the same information. So is it pertinent that the application, you can redact, personal information about the people, but the application and what was granted and what licenses a provider has is very confusing to the public, right? So I think that's very critical for people to understand what a particular place has. Does it have detoxification license? Does it have residential? Is it day-night with community house? Is it IOP? And where are the people living? Like, all of that stuff is difficult for the public to access. More importantly, the inconsistency in terms of follow-up on complaints is also disturbing. So that's another issue. But I think first things first, people who are accessing information for themselves or for loved one, I think are entitled to know what the particular place has had an experience, how long they've been operating, who the owners are, and things like that. Because that's been somewhat of a mystery to most people who have engaged in substance use disorder treatment in Florida.
Okay, thank you, Susan. Jeff, you have your hand up.
Yeah, just a comment about excluding, redacting, whatever. Just want to be clear that unless the Florida legislature is going to amend Chapter 119, the Public Records Act, that they can't just declare in a statute, whatever, that something's not a public record. So I know that people think they can just keep things confidential because they want to in Florida, but that's not the case. It either is a public record or it is not. And simply because an agency has a record does not in and of itself make it a public record. There's definitions for that and whatnot. I think that the concerns that, you know, I represent a large segment of the industry, and Al, I appreciate the removal of unfounded complaints and this and that. My comment to you, and I'll say it to everyone else, is I hesitate to you know, have legislation that seems to be supported by the Trial Attorneys Association come forward that treats drug and alcohol treatment industry different than any other healthcare industry. I've provided to you and you provide to me how nursing homes are viewed. So then why are we reinventing the wheel? Why are we treating drug and alcohol treatment differently? And really that burden always falls on the compliant providers and the cost always falls on them. And it's an additional burden on them. So I don't want to reinvent the wheel with this. I understand that this was foisted upon us at last second by an elected official who wants to see it, and that's fine. I think this is rushed. I think that we need to look at what, you know, we can look at the most vulnerable population that's out there outside of this population. I guess there'd be in nursing homes and assisted living facilities and find out what those organizations do. I did a very easy Google search and found a whole ton of information that's available out there that I shared with you, Al, that we can share with everyone. I'd like for that to be vetted as opposed to just going through this. Hey, does everyone agree with this section? Great, move on. We have legislation now. That's not the way this should work, in my opinion. I think, again, the means don't justify the ends, no matter how well intentioned they are. I personally don't have a problem with this request. I just don't want all of a sudden for us to be carving out drug and alcohol treatment and discriminating against that group of people because we in our collective experience have seen certain things that the rest of society hasn't, and therefore, you know, just because it looks like a nail doesn't mean it needs to be hammered down. I don't want to impose any more burdens on this industry that already gets squeezed by insurance and already gets squeezed by the efforts it puts into social services like housing that doesn't get paid, and shame them with a scarlet letter that doesn't need to be there. So I would like for us to, table this and to look at what nursing homes do. I just provided you with that, and to bring this up at the next meeting after people have time to vet that and determine what works in that and what doesn't work in that. Because at the end of the day, no matter what we say, if DCF doesn't get funding for it, it's not happening anyway.
Well, first of all, we're going to have this conversation big time when we discuss D. But what is the burden on a provider for having their application, their policies and procedures, and their organizational chart online? What's the burden? I got you on D. We're going to have a robust conversation of that.
No, I don't find it. You were talking about things that would be redacted, and I'm like, well, you can't redact them unless they're redacted. That's what I'm saying. So you can't just there's a lot of legitimate business information that doesn't need to be a public record. And so I think that it's a Florida legislature's determination what is and what is not a public record in Chapter 119. And that's what I'm saying is whatever you put in here, there's gonna have to be a Chapter 119 parallel made for anything that's confidential or exempt from disclosure.
Or it could be notwithstanding 119 too.
Right. Yes.
Again,
right. Yes.
Tell me,
Al, if I may,
Yeah, sure.
I'm
Go
gonna-
ahead. Susan.
Thank you. So I have experience, and I appreciate the nod off to trial lawyers because, you know, we do have some purpose in the world. But having said that, I do have experience with nursing home complaints and complaints against licensed healthcare providers, right? So if the complaint is unfounded, it is not public information. Right, and that's fine, but the ability to know that the complaint was made is important. The other issue, which is a provider DCF issue, is that a number of providers are not reporting adverse events that they should be reporting. For example, deaths and things of that nature. So I can tell you that I have a number of DCF files in which I know there was a death and there was no report. So there's sunshine needs to be played on this. The application is what the provider had to give to DCF already. It's already a DCF record. It's not additional to what they had to provide for their licensure. So the application, the policies and the procedures, and all of that information is contained in a DCF licensing file. So that information the burden is on DCF to make it available, not the provider.
No,
Right? The
but
provider had to
right.
do it to begin with.
Right.
If there is a complaint, and Jeff, you can let me finish. If there is
I don't have a choice. I know. Go ahead.
Yeah, you don't have a choice.
I
If
know.
there is a complaint, then it needs to be evaluated and vetted. I appreciate that there are going to be people who make toward complaints about places. But the complaints that and I'm anecdotal, I only have one group of about 40 DCF files where the complaints are not followed up on and things like that. So I hope the secretary appreciates that because that's a big concern of mine. So that's a combination problem of the provider not following the rules and the department not following up on certain complaints. And it's not all providers. Of course it isn't. It's generally just like with medical malpractice, right? It's 5% of the doctors commit 50% of the malpractice. So you're talking about a smaller group. The good operators don't get this stuff and don't have a problem with providing the information. And I get those complete files and there's no problems.
Okay.
So this is about public information.
And let me,
Jeff,
yes,
go
I agree. No, I agree with everything that's said. But I'm hearing a lot of different things being said. Applications. I said there's no problem with applications. They're public records, but that needs to be dealt with in Chapter 119. I'm just making that clear for legislative drafting for those who aren't aware. Separately, you threw in there, or we threw in there, people threw in there the word unreported deaths. I hear that a lot. And let me be clear. DCF has an IRIS reporting system. It's very clear guidelines when something needs to be reported and when something doesn't. When someone walks away from a program AMA and they walked away and they gave the program the big finger and they end up dead at JFK's doorsteps, that provider is not obligated to report a death. It's not on them. And I know that people out there, and yes, I will say the trial attorneys, because I've defended those cases, always try to make a connection that the treatment provider had a fiduciary obligation from the moment someone called them to the time of death to hold their hand all the way through. And that's just not true. And I'm not going to sit here and pretend like that is an obligation of treatment programs when the law doesn't require it. When I say the law doesn't require it, IRIS doesn't require it, because that death or that incident didn't occur within the treatment program's boundaries or responsibilities. If we want to expand that, then let's expand that.
We are getting far afield here. This is nowhere in here that issue is an issue. Okay.
No, I'm just hearing why the trial attorneys want this data.
I know.
That's what I'm hearing.
That's what I'm hearing. To Susan, but
it's not only Susan. Susan represents a large group of people that, it's not Susan, but make their living trying to find ways to intimidate treatment providers to pay them up so they go away. And that's something that we don't talk about in this group, but I deal with frequently, is the intimidation factor, the slander factor of give us what we want, or we're going to file a bunch of complaints against you that you have to go deal with.
Answer my question, Jeff. And anybody else who feels the same way, please pipe up now. But answer my question. until we get to D, which is all complaints, investigative reports, what is the burden on service providers? It's just their license application and their
No, we're past that. I said the only issue there was about if we're going to declare things to be confidential or exempt, whatever, let's just be clear to put language in there about chapter 119.
Yeah, no, we
That's
would
all
have-
I'm
we would
saying
have
about
to.
that.
And the more
Uh,
I think about it, it's a public record anyway. I don't see that anything needs to be redacted because it's not redacted under 119. So I agree with you on that. So now let's get to D, because then I'd like to hear from other people. You know, the original one, and hopefully most of you have read that language. I get it. And I already explained that. So let's move on from that. But all complaints, investigative reports, and findings pertaining to service providers received by the department that result in a violation classified under the three finable violation statutes. What, you know, okay, Jeff, I understand what your feelings are about this. I'm not unsympathetic. You know, I don't want to be a heavy hand here. And by the way, you know how much is going to be on the website tomorrow? If they were required to have that on the website tomorrow? Zero, nothing. Which is one of the problems.
Which is why I think we need to talk about funding, because that's right. If we all were saying kumbaya, we know what's going to happen. They're going to be like, okay, now how are we going to do this?
Well, yeah, and there are provisos being in.
Yeah, that's what I'm saying. You got to tie this to a proviso
like to
because it's not
hear-
going to get done.
I'd like to hear from others about what you think about this. And I get the, you know, fools rush in comment, you know, alluding to that. Anybody else want to comment on this section, whether it's good? If you think it's good, let me know. If you think it's bad, let me know. Should this be on a website? Now, while you're thinking about raising your hand, there is a website for nursing homes where ACA will put up all the complaints
Yes.
and the determinations of the complaint and all the documentation. If you click on the complaint, you get the documents attached to the complaint.
Yes.
Now, if Jeff, you're saying, let's word it like that and have it like that, you know, and this is too amorphous here. What does it mean? You know, how is it going to be created? Well, it's obviously going to be created by rule, but it already exists. It's not like we're making this up and it's not done anywhere else. And I know there's a difference between nursing homes and service providers, but then again, we've been howling that primary care and behavioral health are both medicine. So I don't know that I agree with there's a difference without a distinction here. But anyhow, maybe we need to strike this section and come back next year and do it and talk about it. But I want to hear if anybody else has any comments, because the only comments I've heard have been negative about this section. Other than Susan.
Right, other than Susan.
But I've already heard from you, and I take it that you think that this is a good thing, because then
It is, and it's similar to nursing home, to what ACA does. It's where public goes to get information. I think it's very similar. I will shut up now.
But there is a go ahead.
Al, if I could just.
Uta, thank you, Uta. What is your thought?
Hi, everyone. So I tend to agree just a little bit with Jeffrey here on just that seeing it for the first time and not having had time to look at it beforehand. It's a lot to digest right now. The only thing, and I don't disagree that that this is a good idea if it's modeled a lot like the other health industries, like what you said, like what ACA does for nursing homes and others. I'm not sure that they do it this way in terms of doing every single thing. So I would love for there, again, not that I'm against it conceptually, but again, just having a little bit more time, like if you're including, if you could scroll back up to D, subsection D, for example, everything under 397, 411.7. That includes the tiniest things that have nothing to do with health, safety, or treatment, right? So if somebody's water temperature was off by a couple degrees, or somebody missed an entry into a log, you know, things that are like, and so I would just like to just talk a little bit more in depth and really just spend a little bit more time on, you know, because I'm not sure that everybody would understand the difference between a violation that's a health and safety concern, which is something that I think should absolutely be up there the way it is for other. But again, every single, like, I mean, if you look at the rules at 65D30 and how comprehensive it is, and what all can be a violation to the tiniest thing that really does not have a whole lot of it, something that you want to obviously correct, but I don't know. I just, again, I think devil's in the details, and I think we need to spend a little bit more time to say what is really valuable for the population to know. If you're gonna, you know, if somebody's just gonna look and say, oh, they've had 3 violations. Well, there's a big difference between having violations of medication errors versus, you know, light bulbs being out. So, and that makes a difference, right? And that can really affect providers either in a, you know, in a negative way that's really, not necessarily fair. So again, conceptually, no issues at all, but I do think we need to look at this in a little bit more detail to say, what is it that we really want the public to know?
Okay, Uta, if I get what you're saying, the classification 1 and 2 are non-health and safety, and they can be just technical violations. And those are the ones you're concerned with on 411. Okay. Okay, thank you.
Yeah, just something to think about.
John, you've got your hand up.
Yeah, Al, just weigh in a bit here. In the former policy advisor role, when we were aiming to improve our readmissions rate, we deployed a variety of strategies. I'm all for transparency. Here, we're just looking at complaints. One of the strategies is to deploy a report card, you know, and to make more public where our providers stand in terms of, you know, how, you know, outcomes measurements and the like. So I don't see that in this language, but I can tell you there was a direct effect from that type of strategy and improved readmissions rates.
Yeah, I will tell you that the push from the legislators was more toward that report card. But I think a report card concept, you know, you talk about pushback from the industry. I don't know, Jeff, correct me if I'm wrong, but a report card, you know.
You would expect that from the industry. It's not what's good for the industry, it's what's good for the public. So
yeah.
No, that's not what's good for the industry is also good for the public. Let's not
yeah,
go
come on. You're
I don't, then let's get rid of for-profit treatment entirely then.
Yeah.
We have this conversation every other time.
So am I hearing that for-profit industry is against?
No, you're hearing that
outcomes
providers are
that are more public. Is that what I'm hearing?
No, that's not what you're hearing. You're hearing that it's not only the for-profit industry. There's a lot of people who don't understand the metrics that are going to be used, and the public that's not already educated is going to look at that and make bad decisions based upon bad information from an entity that's regulating a multi-billion-dollar healthcare industry that really does better with child welfare. So that's the concern. If you had ACA doing all this, thumbs up, that would be awesome. Let's go. But we're not, and we're trying to reinvent the wheel here.
Yeah.
And the treatment industry is getting tired of not being treated like medical health care.
Yeah, well,
that's it. That's straight up.
So is that a push to move the industry under ACA from the association?
We've been trying that since 2016. John.
Yeah, I actually, John, that is a goal of many to move behavioral health over to ACA because it is healthcare. You know, it's not children and families per se, it's healthcare.
Yeah, and look, and I've certainly been involved with the ping ponging of where you place mental health and behavioral, you know, in again, another roles. But the strategies to deploy you know, in administratively, whatever the department, remain the same strategies.
Yeah.
You know, that they would be better deployed under ACA versus DCF at the moment, I'm not so sure. But the aim obviously is in more transparency,
Yeah.
you know, in terms of an informed consumer.
You know, with regard to that, I'm not at liberty to share all the phone calls we get on our hotline for years, and they continue up to this day of, you know, of parents whose children have come to Florida. The marketing is still out of control. It's not as bad as it was in 2016 and 17, but there's still a ton of fraudulent marketing going on in the private sector, where they're promising the moon. They're telling parents that your son or daughter will be dead in the morning if you don't put them on a plane now. And you know, more transparency is needed. But I'm getting what you're saying, Jeff, that you know, in between the time I was told to do this, or at least consider doing this, there are other things that I didn't do. I thought they weren't attainable without serious consult and consideration. But there has to be an increase of transparency somehow. There really does. And I'm not saying that we want to paint the industry with a broad brush, but there are still problems. I mean, some people want to say that there are no problems. There are still problems with the industry in terms of insurance fraud. And there are also wonderful providers who care about the people. They care about making a buck if they're private. I got that. But they also care about their patients and are not going to put them in a group session watching Law and Order for 2
Yeah,
hours.
but Al, everything you're bringing up is legitimate. And let me be clear, no one has a problem with transparency. That wasn't the issue. The issue is the ease of disinformation these days and misinformation these days. And if you have someone say, oh, so-and-so had 3 complaints against them, that unlike any other group, like, you know, you go to a restaurant, had a bad experience, and the restaurant can write back, sorry, we were understaffed, or TripAdvisor, your hotel's horrible, and the hotel manager can write back. There is zero response from anyone. And the vast majority of people who complain in our experience are patients that have been told to leave because they relapsed and they didn't want to leave, or they left AMA and they wouldn't be allowed to, you know, weren't given something. Sorry, we're not patient brokering you. So they file a complaint.
I got you. I got you.
And I'm saying it's also,
100%.
but what you're saying too is a vast majority, and I don't think these exist, but you say they do with marketing, that's out of network providers. I work with in-network providers.
I know.
So we have to deal with the reality that there are still out-network providers, and maybe we need to treat them differently.
Well, here, you know, that's why what you just said underscores the reason why we need something like this, because this is not a fly-by-night 5-star system on Facebook. There has to be a violation found. It has to be founded. So this, you know, now I'm taking what Uta said is very important, because what's a violation? You can have 60 violations that don't mean a hill of beans, and another provider can have 1 violation. That's a health and safety violation.
Absolutely.
That's huge.
100%.
So my reluctance right now, and I'm which is in agreement with what you're saying, is we need to talk more about this so that we can do it right.
Yes.
Is something that I'm hearing. But now I still don't hear any reason why not to do A through C.
Yeah, I don't think anyone's fighting on that. No one's fighting
Okay.
on the transparency. I think we just need to be with the information, the depth. It's not that anyone's scared about the information. It's how is it's accumulated, how is it's published. And Ute said it 1,000. I could have said it better. Like, I just want to be quiet, and she nailed it. She nailed it 100%.
If I remove D, I just, you know, say, look, we got to think about this one. We got to really vet it. We got to do it right. Let's look to what ACA does. Who knows? Next year we might have legislation if we can write it, and if we can get it done. You know, ACA's not, you know, the gold standard either in Florida. Sorry, but they do have an oversight. They are overseeing what they oversee. A case in point is they are finding violations where there's none. 0 have been founded. But okay, let's take out D. Let's go E, F, and G. Are there any problems with publishing fines that are assessed, because classification 1 and 2, if they're corrected, there's no fine. So it's only going to be health and safety that are going to be fines.
That's correct.
Okay, fines assessed, and reports or other documentation pertaining to license suspensions and revocations. Notice I didn't put denials, because if you do a records, I did a records request for all denials, revocations and suspensions, and I got like 1,000 denials and 0 suspensions or revocations, because denials are like, you haven't filled out your application properly, go do it right, and it's denied until you get it right. So there may be a couple of thousand of those. So that's not in here, because that a denial is not important. Okay, and then G, inspection reports for service provider licenses. Any problem with the rest of it? We'll take out, let's say we take out D. I'm just going to talk to the legislators and say, look, we haven't had enough time to really vet this. We can continue to try to vet it over the next month, but I agree. I think that, I think that there are good reasons why that we shouldn't do that half baked. So any comments about that? Taking out D and leaving the rest of it? Okay.
Now, my concern is that this has been an ongoing issue for years, and to remove it, I mean, I'm perfectly fine. I appreciate what everybody's saying. It needs to be vetted some more, specifically looking at the violations. But to wait till next year, I'm telling you, there are concerns now whether anyone wants to believe me or not. Specifically, I just hate to wait for this to wait much longer, because there is a standard of care, right, to address questions about whether a particular facility did something correctly or not correctly. We're not just talking about that, right? We're talking about people, real families making the complaints that you referenced. And this is still sort of, not moving forward. I appreciate it needs more vetting, but I don't want it to just die on the vine.
Well, here's one thing that I intend to do. I am going
Yes,
to have a
sir.
meeting. I'm going to have a meeting with the secretary and the legislators in Tallahassee. If they can make the commitment to develop a website input, that's the wrong language, but you know what I mean.
Yes,
That matches what ACA's doing with nursing homes.
that would work.
That's a different situation, because that's already been done. I'll get, what we're going to probably do is we're probably going to have an interim meeting in the beginning of February to just for this issue and any other issue that pops up. It'll be a short meeting, hour or more if needs be. We have to talk it out. You'll get whatever happens. If there's some sort of complaint data that is going to be online, everybody will know about it more than 3 days in advance, and we'll have a discussion about that. I just think that there are enough reasonable arguments on the provider side of this that I think that this is not the time to put it into legislation with this wording. So unless, and Susan, I get what you're saying. Anybody else want to chime in? We have one more section to look at. I don't think that'll be an issue, but anybody else want to speak to this?
Thank you, Al.
Anybody who wants to contact me and talk to me about this, just send me an email, call me up. If you have an idea as to how to do this, and I am thinking that the ACA, I don't think this achieves the ACA's design, is partially why I'm saying that. I think we need to have something that's designed like that.
Yeah, Al, if we need to have our own design, there's no one's objecting to that. I just want, like you said, let's look at that though. Let's figure that out so we do it right the first time.
And again, whether this is in or out, is not up to me. You know, we have legislators who are carrying this in the bill. So, but I'll let everybody know. Right now, we'll plan on a meeting at the beginning of February. And to discuss this, we'll set it and then we'll cancel it if we don't need it. Okay, let's now move to page page 6, section 4. Yeah. Yeah. Page 6. There we go.
Okay.
All right, this is the okay, this is the where is it? Okay, statewide council on opioid debate.
Right.
Right. If you look down now to section 9 through 14. Okay. Hopefully, because this, well, actually, I don't know that we've discussed this. Again, this was discussed, but we didn't have language. Okay. This is merely adding members with lived experience or with chops in the medical field that can be a voice in the opioid abatement council, because the only members of the opioid abatement council are government members, such as appointees of the League of Cities, the Association of Counties, the Attorney General, the department, the governor, the Senate, and the House, basically. So this adds State Surgeon General. We're trying to target to somebody who's a licensed physician, board certified in medicine and psychiatry, at least one of which from the Surgeon General. Florida Association of Recovery Residences. So we have somebody from FAR that at least has a voice when they're discussing the opioid abatement issues. One member appointed by the Association of EMS Medical Directors. One member appointed by the Florida Society of Addiction Medicine, FSAM. Again, medical doctor, board certified in addiction medicine. One member appointed by the Florida Behavioral Health Association. Uta, thank you for that input. And one member appointed by Floridians for Discovery. There's a 15th that needs to be added, and that's FCB, because workforce is a huge issue that needs to be discussed with opioid abatement. So 15 would be, I think it's in the House version, but not the Senate, which would be one member appointed by the Florida Certification Board. Anybody want to chime in? Anybody yay or nay, positive, negative, ambivalent?
Al, just a quick comment, you know, as managing entities manage the non-certified counties. And so there's concern that the counties that get the money directly have fewer rules. And so I think the managing entity should at least be able to participate as well. And that's not unusual in a lot of these commissions where the representative from the Florida Association of Managing Entities is also included.
Okay, what would you be? Because you're the Southeast Florida Behavioral Health Network. Do you have
just like number 13, just like one member appointed by the Florida Association of Managing Entities?
Okay, Florida Association of Managing Entities. Okay. All right. Are you already, as the managing entity, are you already getting like a large share of the money coming out of the Opioid Abatement Council?
Not a large share. We get a regional piece, and then we get the three of our 5 counties are not certified. So we manage Okeechobee, Indian River, and Martin County for about almost 4 million.
Okay, so there actually are counties in Florida that are not represented by managing entities that will be receiving money?
Yes,
Okay.
directly.
how-
Palm Beach and St. Lucie County, just in our area, Broward, Miami-Dade, obviously. It's based on population as to determine whether or not the county commissions receive the money directly from the state attorney's office or whether it went through DCF to the managing entities.
Got it. So DCF is already on there. I'm just trying to figure out if I'm going to get any pushback, and that's the reason I'm asking these questions. And
I
if-
don't think so, because it's routine, and even, Uda could even comment, it's routine for both the Florida Behavioral Health and for the managing entity associations to be on the commission reinvestment grant. There's appointments routinely when it comes to behavioral health and the different task force and commissions.
Okay, Ann. Susan, you have your hand raised?
I do. I wanted to be positive about something. I'm being accused of being negative, but this is the best thing since sliced bread, to have all these people who are, taking care of actual people who suffer from substance use disorder on this committee. It's really exciting. So I think the more the merrier.
Okay. Well, that's a ringing endorsement of
It is.
of the two additions. So I'll let them know. I'll be putting together some. There are some changes that need to be made, but they're more cosmetic. But this is important for FCB and managing entities. Okay. All right. Does anybody have any other sections in the legislation which we've gone over? There are no surprises. Anybody have any sections that they want to talk about that they didn't like what the committee staff did? And if you do and don't know now, feel free to contact me if there's anything in there that you want to suggest be reworded. Okay. Any comments from the task force? Any comments from the public? Anybody want to get out of here 10 minutes early?
You always threaten us with that, Al.
So
Look, I just, if I could jump in real quick, and a couple things in summary. When we look at the earlier Oxford House report, 8 attempts at recovery, it doesn't really say treatment attempts, 3 contacts with detoxification. I mean, they're the numbers that we have to be looking at. And I have to also provide context in this environment of crises, and how many folks are actually we dealing with in that crisis situation. I just once again took a look at the 211 counts numbers. 2022, over 20,000 calls for mental health and addiction. The mental health and addiction calls. Last year, and Sharon's not on the call, that dipped to 16.5 thousand. So there's a much larger pull, and where we're aligning is that initial point of contact, even if it's not crises, is critical. Engaging, appropriately assessing, and driving that care right into a non-clinical environment. And we have to put meat on people, places, and purpose. We have to put meat on social determinants of health. So as I said at the forum that the district held, it's where the aim of the county has always been since I've been here, and affirmed by the board, which is improving longer-term recovery outcomes and enhancing recovery capital, building resiliency, so we don't have 8 contacts or 8 attempts, or we don't have 3 detoxification stays, that we don't have untold numbers of crises. So let's, in the context of all of this, the vehicle by which we're hammering out a lot of this, as you well know, is through the master plan and through the advisory committee. So there's a lot of wonderful things that have been put forth again today, but it all has to make sense in overall aims and certainly overall pieces to the puzzle.
Yeah, thanks for that comment, John. And in light of the fact that that JFK is no longer, I don't know if the county is still subsidizing JFK for their part in the addiction stabilization unit. But clearly, if that relationship is ending, hopefully there are other things that the county can use the money toward, to take these people coming off the street and overdoses that are coming in, and to try to not only stabilize them, but to get them into a recovery, a long-term continuum, which includes housing. So I hope that that's one of the priorities with the county, at least for here in Palm Beach County. And I'm pretty sure it is, John, because I know you. Any other comments? All right. Well, thank you, everybody. And we'll let you know first week in February. We're going to schedule just a legislative review on what's pending. And again, it'll be set for an hour and a half. Probably won't last that long.
Thank you.
Happy
Thank
New
you
Year.
all.
Thank you.
Happy New Year.
Happy
Thank
Year.
you.
Thank you. Happy New Year.